Okay, so for our last panel today, we're gonna transition a little bit from the topic of kind of international health systems and innovation, and we're gonna think a little more specifically about health policy in the US right now. So the focus of this panel is gonna be translating insights from international health systems into Biden health policy, so with a specific focus on current health policy. And we have a very distinguished panel to address these topics. In fact, I couldn't possibly think of better people to have discussing this really important topic of current health policy reform. So, to give a little bit of context, when we had an associated conference in October, focused primarily on academics and academic research, Professor John Gruber, who's on this panel, gave a really interesting discussion at that conference uh, about what were the different contingencies, what were the different kind of health policy reform paths that were possible as a function of the election results. And so Professor Gruber gave kind of some different cases related to this is what would happen if Biden won the election and the Democrats controlled Congress. This is what would happen if the Republicans controlled Congress and Biden won the election. And now that we've seen the outcomes of the election and we're about 4 months into the Biden administration with the thinly Democratic controlled Congress, I think we've learned a lot about what is the path for likely reform look like, what is the agenda for reform. And so I think this is a kind of a perfect time to really dig back into this topic. So with that, let me introduce the panelists and then we'll get into the actual content. So the first panelist I'll introduce is Professor John Gruber. John is the Ford Professor of Economics at MIT, where he's taught since 1992. He's published more than 180 research articles, which, as someone who's published 20, is an extremely impressive, extremely impressive and daunting number of publications. And in 2006, he received the American Society of Health Economics Medal for top health economists in the US under 40. Very germane for this session, John was both a key architect of the Massachusetts health reform and of the Affordable Care Act, kind of interfacing both with research and bringing that research directly to policymakers. And so, John is perhaps one of the most ideal people to tell, or persons to tell us, given what we've done in the past and given the current political climate and economic climate, how can we kind of translate some of the insights we've heard about today to health policy? The second panelist is Professor Limor Daphne, who's the Bruce Raumer Professor of Business Administration at Harvard Business School. Limor directs the PhD program in business economics at the Harvard Business School. And prior to her time getting her PhD at MIT, she was a consultant at McKinsey & Co. Limor's research really focuses on the industrial organization of healthcare markets, especially things like competitive interactions among payers and providers of healthcare services. Limor has published numerous influential research articles in leading academic journals, leading health journals, and leading policy journals. And in addition to that, she's served in a number of very influential policy roles. So she's been an advisor at the Congressional Budget Office, and she served as Deputy Director of Economics at the Federal Trade Commission. Our last panelist is John Kolstad. John is the Associate Professor of Economics at the Haas School at Berkeley. And John, along with me, is a co-director of the Gilbert Center, which is sponsoring this conference and focuses on areas related to healthcare policy and industrial organization. John's research also lies at the intersection of health, industrial organization, of public economics. John was the recipient of the 2018 Ash Econ Medal for the top health economists under 40. And John has also been very active, not only in the research and policy spaces, but also in the technology and entrepreneurship areas of healthcare. So we kind of, now that I've introduced the panelists, I'd like to start the discussion. And what we're going to do is we're going to kick off with kind of short initial thoughts from each of the panelists on kind of the prospects for Biden health reform and some of the key factors and key issues that are being discussed there. And then we're going to open it up to a more back and forth discussion between the panelists. So with that in mind, we're going to start with Limor, and Limor is going to talk about issues related to competition policy under the kind of current health reform efforts. And I know Limor kind of just finished a significant testifying or testimony, a piece of testimony for Congress, I believe last week, exactly on this issue. And so she's very primed for this. So take it away, Limor.
Thank you for that lovely introduction, Ben. Thanks for inviting me to participate in this event. Looking forward to the discussion and honored to be a part of such an esteemed group of commentators. So I'll start with what has undoubtedly been discussed much throughout the day, which is that the US spends a greater share of its GDP on healthcare than any other country, quite a bit more, and that studies show that it's high prices and not sort of the type of services we're using, the quantity of services we're using, the underlying health of our population that is the driver of this high spending. And the worst part of it is that international comparisons show that we lag behind other leading countries on the vast majority of measures of healthcare quality. So that means that we're not receiving the highest possible value for our healthcare dollars and quite far from it. The subject I want to talk about today, as Ben mentioned, is competition in particularly among healthcare providers. Although if the discussion veers toward pharma, we can absolutely go there. There's a lot of attention paid to pharma, and for all kinds of good reasons. But it's 10, 15% of healthcare spend, and healthcare providers are 50%. So ignoring that side of reform, we do so at our peril. So a couple of stats for you. So as most people are aware, the federal government sets the prices that are paid on behalf of Medicare enrollees in traditional Medicare, and state Medicaid programs have also historically had a role in the prices that were paid. That's for the publicly insured population. But the privately insured population relies on market-based prices. And those prices are really high and increasing. So back in the late 90s, private prices in the US were about 10% higher than Medicare prices. In 2012, they're on the order of 75% higher. And today, they're at least, the lowest number I could find, twice what the federal government is paying through the Medicare program, and Medicaid for the indigent is lower. So the private sector is paying more than twice as much for the same services as the public sector, right? So high prices mean we spend a lot more. That's going to cut into worker wages. It also causes health insurance plan designs to shift the burden of spending onto consumers, who then make poor decisions in terms of whether to spend on high value versus low value care. They're not, research shows, great at deciding where to allocate their dollars. They cut back on everything, which leads me to the big conclusion for not such a brilliant conclusion for the administration, but it is we have to do something about our prices. Okay. All right. So three, I think, big picture options. And I'll spend most of my time on the first. One is to promote and preserve competition. And I'll focus on healthcare providers because pharma has its own shenanigans. And through competition, there's a lot of research that shows that competition constrains price growth. That is a solution that is kind of bipartisan. So as Ben mentioned, I had the opportunity to testify before the House Judiciary Committee on antitrust last week. And what the representatives kept on saying was, it's such an unusual hearing because it feels like we're agreeing. So there's a lot of agreement. And I'll talk a little bit about some action items that could perhaps be pursued to make a difference. It's one thing to agree in principle. It's another thing to actually execute on them. So when I get into the recommendations, you'll probably understand a bit why I say that. Option 2. Directly regulate prices. Okay? That's the most straightforward option. I'm personally in favor of not setting the price for every service, but actually capping prices at a high market-based level And I've written a proposal with Mike Chernew and Max Paney of Harvard on how this could be implemented. But effectively, it would be saying within every market, you might cap the highest price that could be charged at 3, 4, 5 times the 20th percentile. And it's, I could get into a little bit as why it's done that way, but basically the higher percentiles reflect market power. So even if you multiply the 20th percentile by 5, you would still save quite a lot of money, and basically you would cap the high prices. And you could also do this nationally and just, have a national binding cap. And then the third option, so the first was promoting competition. The second was regulating prices, that's direct. The third option is to kind of do both at once through the public option, okay? And I'll explain how that might work if Ben doesn't cut me off, because I might be going on too long. But I'm gonna spend the time on the first because frankly, I think that's the most likely. As I mentioned, it has some bipartisan support. Regulating prices is anathema to a lot of folks because they're concerned, right? I don't even need to complete that sentence. I don't think, but it's certainly, not politically popular in a lot of corners. And the public option is related because for a public option and a public insurance option to actually have an impact, you would need to have that plan, whether it's publicly administered or administered through private insurers like the US's Medicare Advantage program. You would need them to be able to pay the public prices as a backstop. So any provider that was a participant in a public insurance program would have to agree that any individual in the public insurance program could utilize their services at that rate, even if they were visiting out of network. So that would make a difference. It's not ultimately so far off from regulating prices. It's got some advantages. But both of those options 2 and 3, my sense is that politically they're much more difficult than option 1. Ben, how many minutes do I have to talk about how we promote competition?
I'd say about 2 more minutes total. And I think that ending, as you mentioned, with kind of a short discussion of the public option is great. Transition
I'm not sure
directly.
I have 2 minutes on a public option. I'll tell you what to do to promote competition, okay? So step 1, we have these competition agencies federally, the Federal Trade Commission, the Department of Justice. Since 2010, okay, their appropriations in real terms, so inflation adjusted, have decreased almost 20%. The economy has grown a lot since 2010. The volume of mergers that they review that have been filed with them for review has increased. It's almost doubled. It's 85%. Okay, so we are doing less enforcement even as we are concerned about, or we have fewer dollars for enforcement, even as we are concerned about greater consolidation in healthcare and in a lot of other key sectors. All right, so that's, I think, pretty straightforward, bipartisan. The next one is likely to be even more impactful, but it is difficult, and it is amending our enforcement statutes. The government now has to prove that a transaction is going to very likely to harm competition before it can try to block that transaction. It is very costly and time consuming to do that. The burden of proof is on the government. Obviously, they have to seek discovery, they have to develop expert opinions, etc. Shifting the burden of proof, at least under certain circumstances, to the defendants would do a lot. And I could go on, but given the time, I won't. But some of these rewriting, modifying the antitrust law is difficult. Ben asked for a couple moments on the public option. I'm hopeful that John Gruber will have time to talk more about this. But the public option is something that has been proposed by the Democrats for some time, which is to say, let's not do a national takeover. Let's just make a national option available that is informed by public guidelines. And as I mentioned, for it to have teeth, it's going to have access to public prices. I have not seen a detailed proposal put forth that describes what the public option, as the Biden administration is talking about, is going to look like. If anybody knows more, that'd be great. I looked it up recently, 20 minutes ago, and couldn't find the details. That's pretty important, because I don't think if we could talk about it, but something that is labeled public but is just a private insurance program is going to have similar problems to our current private insurers.
Great, thanks so much, Limor. And one of the reasons I was interested in having you end with the public option was exactly for the transition to what John Gruber is going to talk about. The public option, one of the things, how it's kind of one of the ways it slots into what you were talking about is that it is this kind of nice, potentially nice middle ground between direct price regulation on the one hand, and kind of on the other hand, kind of promoting greater competition, and that leading to kind of disciplining of prices through that avenue.
Yeah, Ben, and if I could just, sorry,
yeah, please.
I'm going to add one more thing about the price regulation. One reason it's neater is that if the public option insurers have the backstop of the public prices, they don't have to pay those prices. They could just, the maximum they end up paying is what the public sector would pay. Or something close to what the public sector would pay for enrollees. So they could still creatively compensate.
Exactly. So have that backstop of prices, but at the same time still allow for potential innovations in the private market. So with that, John Gruber is going to talk about kind of the potential improvements to the Affordable Care Act, and kind of how we can achieve the goals of both kind of increased access to healthcare while also lowering costs. You're on mute, John.
So the thing I want to patent is what I call the Zoom score, which is a little black box in the corner that says the % of times you talk on mute. I don't know why anybody can come up with that. I think I worry that the summary of where we're going on healthcare could best be summarized by a headline in Vox today, which said, "Why Democrats' ambitions for healthcare are shrinking rapidly." And so basically, during the campaign, there was a very ambitious agenda for healthcare reform. I think a small part of it's been realized that it's not clear if that will even stay and how much more we'll do. So let's talk about what's going on. So basically, Biden had proposed three things. One was to improve the affordability of insurance on the ACA exchanges. The ACA exchanges had two fundamental problems. One is that the subsidies that make health insurance affordable ended at 400% of poverty. As a result, really very few people above 4 times the poverty line were enrolled in the exchanges. So Biden proposed to cap that at 8.5% of income, cap the amount people had to pay for insurance at 8.5% of income for everyone, as well as to make the insurance plans more generous. The other problem with the exchanges now is for lower income people, they can be subject to quite high out-of-pocket cost limits. For people at 2 times the poverty line, the out-of-pocket cost limit can be something like 25 to 30% of your income. So for people who are sick year over year, that's really unaffordable. That was the first part of his proposal. The second part was a public option, which Lee more nicely described. And the third part was lowering the age of Medicare eligibility. A piece of the first part was in the American Recovery Plan. So in the American Recovery Plan, which passed right at the beginning of the Biden administration, there was a temporary increase in these premium subsidies. So now anyone in the exchange, it's now free up to 150% of the poverty line. So for those of you who haven't memorized the poverty line for individuals around $12,500. So up to about 1.3, up to about 1.5 times that, insurance is now free on the exchanges, and it's capped at 8.5% of income for everyone. However, this is temporary. It only lasts for 2 years. So in his recently released Families Plan, President Biden has announced that he'd like to fund that, to make that permanent, which would cost a little over $200 billion over the next decade. What President Biden couldn't address in the short run, the American Recovery Plan, and unfortunately I think doesn't address in his new plan, is the other problem with exchanges, which is that for many poor people, the cost sharing is prohibitive. And I think it's unfortunate to address that, and I hope he will endeavor to do so. There's been no mention of the public option. So Lee Moore, we don't have details because they haven't given details. There's been no mention of lowering the Medicare eligibility age. So basically, and there's also been a brief mention, but no great plan for really the fundamental problem facing insurance affordability in America today, which is the so-called Medicaid gap. To remind our listeners, when the ACA was passed, a key part of making insurance affordable was making health insurance free through the Medicaid program for everyone below 133% of the poverty line. That was made optional by a Supreme Court decision, which didn't really bother people because since the federal government was basically paying for it, we figured all the states would take it. But for political reasons, about 12 states do not make their lowest income individuals eligible for Medicaid. This is a problem because since the ACA presumed every state would have this option, technically those below the poverty line are not eligible for the subsidies and the exchanges, leading to the crazy situation where someone at 99% of poverty has no option, and so at 101% of poverty can get insurance for 3% of their income, which makes no sense at all. And in particular, makes no sense at all that states wouldn't expand Medicaid because it's paid for by the federal government. Literally, the federal government is saying to Ron DeSantis of Florida, you have 1 million uninsured low-income individuals. We will make other states pay for you to cover them. And he's saying no. It's political malpractice, quite frankly. It's nothing short of that. But nonetheless, it exists. And the question is how you address it. One way to do it would be through the public option. We'd have a public option that allows individuals to enroll in those states that didn't expand Medicaid. Absent that public option, it's sort of hard to know how you're going to basically encourage those states to get on. And that's a remaining big problem. I think to do broader reforms for coverage, as well as broader reforms for lots of things, is going to require more funding. And a major source of funding is prescription drug price reform. And Limor mentioned this, but let's focus on this for a minute. The major proposal there is H.R. 3, the Democrats' proposal to limit prescription drug prices by allowing the Secretary of Health and Human Services to negotiate those prices for the first time for the Medicare program, and in particular to give those negotiations teeth by limiting the prices to 120% of a market basket of what's charged in other countries. CBO has scored this as saving $500 billion over a decade, which could easily finance the remaining fixes we need to the Affordable Care Act. In fact, it's a natural tie between using that money to funding the permanent fixes of the Affordable Care Act. But CBO also said, based on research, when you limit pharma revenues, you'll limit the amount of R&D they do. And CBO is actually bold enough to estimate that if HR 3 passed, we'd have 30 fewer drugs per decade. I think so CBO sort of set up this tension of kind of save money now, have fewer drugs in the future. I think that's a false tension. It's a false tension as I lay out in my book with Simon Johnson, Jumpstarting America. It's a false tension because there's incredibly productive public research, public R&D opportunities where even a fraction of that money could offset this savings. So let's just give you one example. If we use estimates from researchers at MIT, taking 1/4 of the savings, less than 1/4, $100 billion over 10 years, and giving it to NIH will result in 80 more drugs per decade. Okay, a vast increase well exceeding the level that CBO scored as reduced private sector innovations. This is a false choice. We can both regulate price drugs and have more innovation and have plenty of money left over to do things like fill the Medicaid gap or deal with shortfall or deal with another priority. We talk about healthcare. You know, one thing we should talk about as well is President Biden has proposed a $400 billion investment in what he calls the caring economy. One incredible irony of COVID is that the U.S. was willing to essentially shut down our economy and spend $3 trillion to save the lives of elders. And yet once COVID's over, we'll go back to putting them in shitty nursing homes and not caring about how we treat them. And that's horrible. For a fraction of what we spent to stop COVID, we could massively improve the care of elders in our nation and be more like other countries, which have terrific long-term care systems. President Biden proposed a $400 billion caring economy package as part of his infrastructure plan. And so basically, that is another important topic that needs to be discussed. It needs to be financed. We need to address the long-term care needs of the elderly as well. And I think that's another important thing to keep an eye on as the healthcare debates go forward.
Thanks, John. And I think, we're going to, after we hear a little bit from John Kolstad, we're going to go back to these issues and think a little bit about kind of the potentially most impactful short-run policies, as well as potentially the things we may want to pursue in a longer-run agenda, say 10 to 20 years from now. So John, you know, Limor talked a lot about competition in the healthcare sector. John talked about access in the Affordable Care Act. Another thing that's particularly important in the current landscape are both things related to administrative costs and the administrative burden in the healthcare system, as well as just the general issues related to the use of technology and technology adoption. I was wondering if you could both kind of touch on that for a little bit, and then take a step back and connect that to the international context that we've heard about earlier.
Sure. I will attempt to do those things. It's both easy to follow because we've had so many good ideas, and hard to follow because they're so excellent. So I'll see what I can do. But I did have sort of four big buckets building off what you said and what we've heard, which is administrative costs, sort of the standardization and market function, thinking a little bit about the structural challenges that we face, and then the caring economy, sort of as John Gruber just put it, but the broader home health, post-acute, and the broader economy that relates to health. And I'll frame that within a little bit of the Biden health policy, which is with the political structure as we have it, with the amount of money going into infrastructure and jobs, and the seeming priority of that relative to health policy. I don't think that shuts out big opportunities, because the reality of change is often in the making of rules and in the execution within agencies. And a lot of what I want to talk about might be potentially effectively done through there. So administrative cost, I think, is a huge opportunity. And I showed it in my opening remarks. Kind of that's where one place where the US really stands out, that we have a lot more overhead to deliver healthcare. If I think of characterize a simplification of a small city in America is that the widest building is the hospital and the tallest building is the health insurance company. And they're filled with cubes of people basically arguing back and forth over the same claims. And that's a big opportunity to potentially improve efficiency without having to make some of these very difficult trade-offs that we've heard about throughout the day, which is what is the right technology people should have access to, and we will get there. And that is an important trade-off and decision to make, kind of how do we want to trade off other expenditures versus life years. But before we get there, potentially having an easier to navigate, less cumbersome, and more straightforward healthcare system where we reduce administrative costs could be big. You're seeing some efforts in that direction, but I think that's where more of a role for, particularly for Medicare and to some extent Medicaid, in leading the way and generating innovations. I think we've seen kind of the organizational innovations we heard about before, things like more effective or efficient pricing, different ways of paying for things. Often they come out of Medicare and then are subsequently adopted by private plans. More of that could facilitate things. I think that's a big opportunity. It also relates to prices. It's not clear that this is a mechanism, but if you think about the increase in cost sharing that the US has faced, so people are paying more out of pocket, ostensibly to lower use of low value care and to get doctors to negotiate lower prices with plans. Along with that comes the fact that now local doctors and health systems have to spend a lot of time chasing down money, right? They're in the collections game. And I think, you realize how many more back office staff are needed to kind of go after the kneecaps of patients, as it were. That translates into cost somewhere, and it probably translates into prices. So I think, again, this is an area where more effective competition as well as regulatory oversight in some capacity could be very effective. It's also a place where you could harness some innovation. There are lots of smaller technology companies focusing on really a next generation infrastructure for this. And if you had a system in which plans or providers were rewarded, or there was more efficient structure, you could see a lot there. The second area I want to touch on is the standardization of choice. And I think this is an area where we can really learn from other health systems. So when, the Affordable Care Act is a backbone for at least a big piece of healthcare in the US and health policy in the US and what Biden can work on. And in addition, we rely on choice in lots of capacities. So Medicare Advantage, employer-based plans, yet very little is put into how effective people are at making those choices and to facilitating it. And if we think that we're going to get lower priced, more innovative products to market, you have to have someone demanding those products, right? Why do we get new and better computers that are running faster and faster every year and are easier to use? Because we figure out that I like this particular Mac more and I buy it. If you don't have that, it's not clear you're going to get the kind of innovation and creative destruction in the market that you might want. So I think that's a big area that relatively small kind of rule changes or changes to the way marketplaces are structured could be very effective. And one good example, which you heard in the last panel, is the Medicare Advantage. We think that plans do more innovative investment, arguably because they're competing in a more structured market. Different states and Obamacare exchanges overall could potentially facilitate this. And I think that's a big opportunity where things like standardizing what it means to be a particular type of benefit, bronze, silver, or gold, could facilitate a lot more competition. Instead of focusing on making little gotchas at the edge of your benefit, you'd have to compete over delivering the same plan for a lower cost. That's what we want. And so I think that's a big opportunity, again, within the sort of rule making rather than in the grand legislative shift. The structural challenges, and I'll be quick, so I want to open things up and come back to it, but the structural challenges that I do think are hard are that it's very fragmented, that even a pretty large health plan only typically is a small share of a doctor's patient panel. So if a health plan wants to implement a really innovative approach to managing care for diabetes, they might go for it, and they're not really going to change the behavior of physicians very much, because even if they double their pay, that's a small share of the total patient panel. So this leaves it to really Medicare to lead the way. And I mentioned that we've seen evidence of this, but I think it underscores that it's not just the way care is delivered for seniors, it's really the way kind of innovation disseminates into the market, which is pretty different than a lot of other domains of the economy, and something that should be thought about in kind of thinking about Biden's health policy going forward. And there are a lot of lessons from other countries that can be brought in that capacity. And the last thing I would say on the caring economy that John Gruber mentioned is really a key piece of the infrastructure bill. I couldn't agree more that this has been neglected heavily. And this is an area where other countries have a tremendous amount to teach the US, that other countries have relied on payments to family members. They've relied on much more rapid deployment of relatively less skilled caregivers into the home very quickly. And it's an interesting timing, because I think you have seen that actually propagate a lot more in Medicare Advantage, for example. And I think that this would be a great time to do it, not least because it's in the infrastructure bill, but also because fundamentally things have shifted. As we heard in the last panel, we have accelerated adoption of technology, even by the unhealthy and seniors, in a way that, we've consolidated 10 or 20 years of technology adoption into 1 year during the pandemic. And building on that to create ways to either use technology or labor for people who are looking for jobs to actually facilitate caring for particularly elders and the disabled and sick in places where they want to be cared for, where it's much more cost effective, and frankly, where they're happier, and there's better outcomes. That's, I think, a huge opportunity that really builds on what we can learn from other countries and where a lot of the savings come in a variety of other, particularly European health systems.
Great, thanks, John. So you guys have already touched on some things that I think of as kind of longer run reform aspects. So one of those things is certainly the discussion on the caring economy, which is something that will be kind of a longer run systemic change. Technology adoption and use is another thing that falls into that category. One of the things that's kind of struck me kind of thinking about policymaking over the past several decades is that when you think about kind of what led, for example, to the passage of the Affordable Care Act, a lot of the kind of seeds for that reform, which was really a transformative reform, were laid in the 1990s, both based on kind of academic research and policymakers, and especially people working at think tanks, thinking about how can we set up a managed competition style insurance system. One of the things I'm interested in hearing from the panelists on is, what are some kind of longer run reform areas? So things that kind of maybe 10 that could actually be implemented 5, 10, 20 years from now that aren't kind of currently really in the health policy ethos or kind of in the health policy discussion, that we can kind of start a discussion on and really think about how can we kind of integrate these things into the US context. Just to give you an example, and then I'll let you guys kind of take this and take it into a discussion. Earlier this morning, Carol Proper spoke at some length about the health technology assessment in the UK system, and how in her view that's been kind of a very successful way to manage costs, and something that's been by design in some ways very absent from the US healthcare system. So that's one example, but you can feel free to take the question in any direction you want.
So I guess I have two examples. I mean, one I'll just mention because it really Limor hit on it, which is I think we're going to have to ultimately regulate prices. I mean, we've tried to get around, we've got this backdoor idea of accountable care organizations as somehow allowing us to get out of regulating prices, but it hasn't worked. I think we're going to have to regulate prices. I think, it's coming for drugs. And I think, over the next decade, it may start to come for other kind of providers too. So that's Limor's area of expertise. So I won't say more than that. The other place that I think it relates to Carol's comment is I think health technology assessment is coming and sort of has to come because we're on the cusp of seeing a wave of highly expensive and highly effective genetic therapies. So my estimates with my co-author Andy Lowe are that over the next 15 years, we'll see about $300 billion of spending on genetic therapies that are already in the pipeline, ignoring any new genetic therapies that are coming out. Just in genetic therapies already in the pipeline. The problem with genetic therapies is it goes beyond health technology assessment, because health technology assessment is about saying, let's not pay too much for things that aren't that effective. But these treatments are unbelievably effective. To me, one of the most stunning developments in health policy of the last 10 years is when one of the first truly novel genetic therapies came out, Zolgensma, which treats this horrible condition called spinal muscular atrophy in babies. And it was priced at $2.1 million, and that was a bargain. I mean, $2.1 million to basically take a disease which would lead a baby to have a horrible life and die by 2 and keep them alive for, as far as we can tell, a normal lifespan. It's totally worth it. It's the first drug I know of that was released at the same price in the UK and the US. Approved at the same time, released at the same price. It's 2.1 million in the UK too. That highlights the fact that health technology assessment is not enough. They have great health technology assessment, but it's useless when something is incredibly expensive and incredibly worth it. I think that's going to be a challenge that maybe not over the next decade, but over the next 25 years, societies are going to have to face the fact that we may have to make some hard calls about whether we're going to pay things that actually are cost effective.
And what do you view as kind of the main issues in terms of the trade-offs for paying for things like that? So, I mean, it's clear from what you described, and it's clear just from what we see scientifically that these therapies really are worth it in some sense, right? It's certainly worth it from an individual sense, but then from a social sense, it really gets more into kind of almost towards the macroeconomics of, do we want healthcare to be 30% of GDP if it's extending lives and just delivering amazing lifestyle benefits? You can feel free to say, well, it's kind of a political issue, but.
No, I mean, I think once again, there's two aspects that we're asking then. One is that ultimately it puts the pressure on a system which regulates drug prices on something which is not based on inputs, but rather based on outputs. That ultimately, we like to think that prescription drug price regulation based on value will allow us to control drug costs, but it won't. As generic therapies, we may have to regulate prescription drug prices like we regulate utilities, which is on the cost of production. That may be the only long-run way. Now, that would have to include enormous reward for risk-taking. It's not just like electricity. It's not just the cost of production. But essentially, you could imagine a system where you regulate drug prices based on the cost of production plus some premium is determined by how much money they need to make to get the market interested in funding their development. And that's still probably below $2.1 million. So I think one answer is we're going to have to move to a new system of more like utility when we regulate prices. The other is we are going to have to start having hard debates about is it worth it? And my view is it is. Now, I gave you a big number, $300 billion over 15 years. Note that's a cumulative number of 15 years where healthcare spending will be in the order of $50 trillion, 50 trillion dollars. So it's not that much. There's no one, in my view, more sympathetic in society than babies born with genetic deformities, with genetic disadvantages. No moral hazard there. Okay, so basically, I think we should just pay for it. And if we have to raise taxes, raise taxes. But, you know, I think ultimately we need a smarter regulation, but subject to that, we should be paying for this. This is a needy population. This is what wealthy society should do.
Yeah, and Limor, you know, I know earlier when you were speaking, sorry, go ahead, John.
I would say one point in that, which I think relates back to our earlier discussion about having the German style, basically having a more non-political or politically insulated entity considering these things. I think that will become increasingly important in that domain, if you think about it, in the sense that I think John makes a great point, and to the 30% of GDP, if you're a relatively wealthy country, extending periods of life is much more valuable than consuming extra stuff in fewer periods in an existing period. And so I think that it will become important. And, you know, we've seen the inability to take science seriously in the political discourse. And this, you know, if it starts to get to that large a share of GDP, I mean, I'm not sure what a big share is. We're already at 18, but I think it underscores the need to have the ability to act outside of the at least day-to-day political football.
Yeah, and Limor, you know, earlier when you were talking about price regulation, you were focused on providers, and you kind of laid out these three paths, one of which was kind of more focused on letting the market function, so to speak. You know, based on John Gruber's comments, it does seem like in the drug space that you know, may be more challenging, especially as we move more towards an environment with these high cost therapies. So I want to get your reaction to that in the drug space, which I know is different than what you discussed earlier. You're on mute, Limor.
Just up my Zoom score.
Yeah.
All right. So this is a really great discussion. As John mentioned, I agree. I mean, as I got to do something about the prices. And the one other idea I'll throw out there, apart from just, you know, regulating, capping the prices that has been discussed, is Alan Antobin's managed competition. The reason that our prices keep climbing, whether it's for healthcare providers or for drugs, is fundamentally because we're willing to pay them, right? So either you say you're not allowed to pay, and one worries because you can come up with creative payment arrangements outside the regulated prices that enable you to capture the profits that you know, whatever people are willing to pay. So I don't know how long that really works. Or you change the demand where the purchaser. So if I am purchasing my car insurance, I'm willing to pay for a certain quality level, certain choice of what body shops I go to, all of those things. And once it is in consumers' hands with a certain cap on, you know, that the employers provide, not a cap, but the employers are only willing to increase that a certain percentage a year, we'll have consumers' price sensitivity helping to discipline the market. That is not a super popular idea, but economists, I think, not all of them uniformly, but think that could be one way to go. On drug prices, I think it's likelier than regulating provider prices. There's a lot of discussion on it. And the reason I think that is that when you regulate drug prices, all the innovation that currently exists is already there. You're making a trade-off in terms of future innovation. There's big dispute about how much trade-off you're making and what kind of innovation you're going to be potentially foregoing. And they're not giant employers the way that healthcare providers are, right? So you don't have an immediate hit on wages, employment, all of that. So we may really see something there. And then the way to do it, it seems that is really what John said, Kolstad, in particular, about having some kind of nonpartisan objective entity valuing things and correcting for the market failures, such as the Me Too drugs that get shifted and instantly get paid more. The problem that John Gruber talked about is not one that I have heard addressed in the public domain, and is one of those, not even 15 years, but like within 10 years, we have to do something about it, is right now, I want somebody to quantify the pharma dollars or biopharma investments going into creating these precision medicine, gene therapeutic solutions and what a reasonable rate of return would be on that, and what people are projecting we're going to spend on all of these cures, because I suspect those numbers would suggest that we have some kind of a bubble going on, and the sooner we provide signals as to what we value and how much, the more efficient the allocation will be.
Yeah, and from a profit-making standpoint, drug companies right now, of course, their model is built off of, blockbuster drugs hitting and earning a lot of money based off those blockbuster drugs. I think this question is probably mostly for John Gruber, and you may not know the answer, but do you have a sense of which, there would be a rate of return that drug companies would be willing to accept, in the sense that, right now, for example, their portfolio is risky. What if in some ways you were able to kind of reduce that risk, but it give them some dedicated rate of return? So with electric utilities, this rate of return isn't that high over cost, and it may need to be higher with drug companies.
I mean, look, this is a theoretical concept that we are so far from being able to implement, but I think it's a discussion we should be having. My colleague Rena Conti at BU is thinking about this. And I think it's super hard because the costs, first of all, the costs are hard to measure when you're drug company developing 30 drugs. How do you even tell what the costs of production are or research are on any given drug? And then you've got the problem you have, Ben, which is you have to offer like a ginormous rate of return because of the incredible risk. I guess my point is you could offer a ginormous rate of return and still end up with prices lower than what we're getting for things like Zolgensma. So I think, it's really, I think it's an area worth exploring, but I don't have any great answers yet.
Yeah, no, that makes sense. And in our last couple of minutes, we have 3 minutes left. I thought maybe I would even move a little more towards the bigger picture, even though we're already at a pretty big picture level. So John Gruber mentioned curative gene therapies, and that seems like something that's very likely to transform how we're thinking about the healthcare space overall. Kind of in your view, I guess like one other example of this, by the way, is the COVID pandemic has certainly transformed a lot of ways that the healthcare system is operating and a lot of what we understand about the healthcare system. Are there any kind of big picture changes, whether kind of coming from within the healthcare system or outside the healthcare system, that you foresee kind of really having an impact on the way we think about healthcare policy, but which kind of people aren't currently discussing that much? So a couple of the examples of this could be, for example, the role of universal basic income and kind of transforming how we think about subsidies in the Affordable Care Act, or for example, technologies related to care access via telemedicine and how we think about that as relating to provider payments. You could pick one of those, or you could kind of jump on another thing that you think is important. And why don't we kind of do each of you in turn, since we're wrapping up here.
Limor, you went first.
Go ahead, Limor.
All right, I'll go first. All right, just one idea, something that I think we'll see more of, it'd be exciting, take some time, is care navigators. So John Kolstad talked a bit about, reducing waste in the system through lots of simplification of claims adjudication and payment. I expect that, the Amazons, the Googles, will make it so that I am directed more efficiently to providers who are then rewarded for taking care of me more efficiently and satisfying me. Your turn.
I'm going to say technology for long-term care. I was talking to a VC expert the other day, saying he didn't think thinks in 5 years, every old person could have a virtual image that sits in their room and talks to them and keeps them company. And what could that do? And, more broadly, just in general, the whole sort of social determinants of health area. What are, Ben mentioned universal basic income. How do we start? Remember the fundamental fact that if you add up healthcare spending plus social services spending, we're the same as Europe. We just reverse the proportions. So what do we need to be doing on the larger social determinants of health spending?
Yeah, I'll build on that. It really is that I think the move to telemedicine, the baby boom that is now aging, is just more accommodating to these things. I think that the fundamental structure of caring will change a lot. That'll be, and potentially quite rapidly. The other is kind of related to data infrastructure. I think we'll see much better infrastructure, sort of a combination of regulatory and public investment with private sector data collection. And that's going to potentially shift both the way care is delivered or navigated, but also the way we understand costs. And I think this gets back to John's point, which is a really important one to remember, which is social determinants of health are popular in the sense of lots of other things that happen outside of the healthcare system are pushed into the healthcare system because that's where we pay the cost. But it's not, we'll also probably realize that lots of things that are well beyond the purview of a doctor are hard for them to deal with. And so how do we kind of integrate things better? And I think actually data infrastructure is really important for that, to say it's about all of these things coming together that affects a person's life and their cost.
Thank you, guys. Thank you so much. This has been a really interesting and an exciting panel. And I think we kind of touched both on, some of the really pressing short-term issues that the Biden health team is working on. And also you guys dealt very well with my kind of surprise questions on the kind of bigger picture and what are some of these more kind of transformative long-run things that kind of should be in the discussion, in the broad policy discussion, but in some sense aren't there, and in some sense may be crowded out by some of the more urgent kind of short-term things. So thank you guys so much. And now I'm going to transition just to the closing remarks for the conference. I think that the goal of this conference, especially, is to think about the lessons that international health systems can provide as they pertain to U.S. health reform. Now, much of the discussion in the U.S., especially in the policy space, is on more short-term oriented policies, and so even in the healthcare policy space, short-term can mean 3 to 5 years, so not that short-term in some sense. And part of the issue with that is that when we're thinking about kind of short-term policies and how to kind of move towards the bigger picture goals with these short-term policies, it's actually hard to integrate and bring in lessons from international health systems, because international health systems, if you just take it kind of as it exists as the status quo, many are quite different in structure and seem quite unusual or quite weird from the perspective of US healthcare policymakers. And so part of our goal here has been to take a step back, think about what policies are being implemented in international systems, how effective have those policies been, and then try to fold that back into the US health system with the idea that even if these aren't policies that we're going to implement in the next 3 to 5 years, which of course is highly unlikely, these are certainly policies that we can talk about, kind of develop robust public and policy discourses on, and then hope to really do something transformative in the US healthcare system over 10 years, 20 years, or 30 years. And I think, we've heard this today related to many areas kind of spanning the healthcare sector. So we've heard really interesting comments related to innovation and drugs and technology assessment, which especially other countries do quite differently than the US. We heard very insightful comments on how should we pay for healthcare? How should we pay healthcare providers? How should we pay for drugs? We've heard a lot on the role of technology in healthcare and how, for example, Taiwan has made great use of technology to implement what seems like a very kind of magical and efficient healthcare system in a lot of ways. And so I think that the goal of this conference has been to kind of understand first, what are these other systems doing? And then think, okay, in the medium to long run, how does this fit into our policy agenda in the US? And so I think that all three of the sessions today really are kind of nicely fit together in order to help get this discussion really started, and hopefully to help generate further discussion on these bigger picture issues that might not be being discussed as central parts of the US health policy discussion right now. So with kind of that backdrop in mind, I would like to one more time thank our panelists throughout the day. I'd also like to thank the Gilbert Center staff who helped make this conference possible. I think that, without the panelists, we wouldn't be able to get this robust discussion started. And especially Kathy Garcia and Cynthia Okita on the Gilbert Center staff have been instrumental in kind of making this event a possibility. So I'd like to thank them. Also, very importantly, I'd like to thank World Health Systems Facts.org, who's the sponsor for this conference. And I'd really like to thank them both for kind of pulling together the fantastic website that they're running that is really geared towards bringing in and synthesizing facts about different international health systems in one place. But also thank them for kind of realizing that those facts need to be a part of the US healthcare policy discourse and US healthcare policy debates. And I think we've seen their commitment to that by kind of facilitating and sponsoring a conference like this. So I'd like to thank them. So that concludes the conference. We look forward to continuing this discussion going forward. And thank you to the participants and attendees as well for kind of devoting your time to this important topic today. So thank you very much.